Most people assume it's a fiber problem, or a water problem, maybe even a "you're just not eating right" problem. But new research points to something happening deep in the pelvis that has almost nothing to do with diet, and it's shockingly common. Let's start with what everyone gets wrong first. If you ask most people why stool gets stuck, they'll say the same three things: not enough fiber, not enough water, or weak bowels. And for decades, that's exactly what most people were told. Eat more roughage, drink more water, maybe try a stool softener. It sounds logical. Stool is dry, so make it wetter. Stool is hard, so make it softer. Simple, right? Except for millions of people, none of that works. They increase their fiber. They drink more water than they know what to do with. They try every over-the-counter remedy on the shelf, and the stool still sits there, right at the exit, refusing to move. That mismatch, doing everything right and still getting stuck, is the first clue that something else is going on. Because if this were purely a fiber or hydration issue, fixing fiber and hydration would fix the problem. For a huge portion of people, it doesn't. So what actually explains it? The answer lives in a muscle most people have never heard of, the puborectalis muscle. This is a sling-shaped muscle that wraps around the lower part of the rectum, and its entire job is to help you hold stool in when you're not ready to go. When you're just walking around during the day, that muscle stays contracted, creating a kink in the rectum almost like a garden hose bent at an angle. That kink is what keeps stool from leaking out unintentionally. Here's where it gets interesting. When you actually sit down to have a bowel movement, that muscle is supposed to do the opposite. It's supposed to relax and straighten out, removing the kink so stool can pass through smoothly. That relaxation is not something you consciously think about. It's coordinated by nerve signals and muscle memory, almost like blinking or swallowing. But in a large number of people, that relaxation does not happen. Instead of loosening, the puborectalis muscle does the exact opposite. It tightens even further at the exact moment it should be letting go. Doctors call this paradoxical contraction, and it's part of a condition known as pelvic floor dyssynergia, or sometimes anismus. Instead of the pathway opening up, it essentially closes shut, right as stool is trying to leave. The stool arrives at the exit, and instead of a clear path, it meets a wall of muscle that refuses to move out of the way. This is why so many people describe the exact same frustrating sensation, the feeling that stool is right there, that it should come out, and yet no amount of pushing seems to get it past that final stretch. It's not that the stool is too hard or too far away, it's that the muscle guarding the exit isn't opening on command. And this explains something that confuses a lot of people: why pushing harder often makes things worse instead of better. When you strain and bear down against a muscle that is contracting instead of relaxing, you're essentially fighting your own body. The harder you push, the tighter that puborectalis muscle can clamp down in response, especially if the nerve signals telling it to relax are miscommunicating with the signals telling you to strain. Over time, this creates a frustrating and sometimes painful cycle, one where the effort to push stool out actually reinforces the very blockage you're trying to clear. So why does this happen in the first place? Why would a muscle that's supposed to relax on command suddenly start working against itself? The truth is, there isn't one single trigger. There are several patterns that show up again and again in people who deal with this. One of the most common patterns is years of ignoring the urge to go. Think about how often people delay a bowel movement because they're at work, in public, traveling, or simply too busy. Every time that urge gets pushed aside, the body learns something. It learns that the signal to relax and let go isn't actually meaningful because it keeps getting overridden. Over months and years, this can retrain the communication between the brain and the pelvic floor, making the relaxation reflex weaker and less reliable exactly when it's needed most. Another major contributor is chronic straining itself. This sounds almost backwards. Wouldn't straining help push things out? In the short term, maybe. But long-term, repetitive straining teaches the puborectalis muscle to brace and tighten as a protective reflex, the same way your shoulders tense up if you're bracing for impact. Instead of learning to relax under pressure, the muscle learns to guard. Stress and anxiety play a bigger role here than most people realize. The pelvic floor is deeply connected to the nervous system, and it's one of the most common places the body stores physical tension. People under chronic stress often clench muscles they aren't even aware of: jaw, shoulders, and yes, the pelvic floor. If that muscle is already living in a state of low-grade tension throughout the day, asking it to fully release on command becomes much harder. There's also a physical component tied to posture, particularly with modern toilets. Sitting upright at a 90-degree angle, which is how most Western toilets are designed, doesn't fully straighten the natural kink created by the puborectalis muscle. A more squatting position, with the knees higher than the hips, mechanically helps that muscle relax and unwinds the angle more completely. This is part of why studies comparing squatting posture to sitting posture show meaningful differences in how completely and easily people empty their bowels. Childbirth and pelvic trauma are additional contributors, especially in women. The pelvic floor muscles can be stretched, weakened, or thrown out of their normal coordination pattern after vaginal delivery, certain surgeries, or injuries. This doesn't just affect strength, it affects timing. Muscles that used to relax and contract in a smooth, coordinated sequence can end up firing at the wrong moments, including tightening when they should be loosening. Now here's where this becomes especially important to understand. This condition often gets mistaken for regular constipation, and that mix-up leads people down the wrong treatment path for years. Regular constipation is generally about the stool itself. It's too hard, too dry, or moving too slowly through the colon. The fix in that case really can be more fiber, more water, gentle movement, and time. But when the issue is a muscle that won't relax, none of those interventions address the actual mechanism. You can have perfectly soft, well-formed stool and still get stuck at the exit, because the problem was never about the stool in the first place. It was always about the muscle guarding the door. This is why so many people describe a very specific and often confusing set of symptoms: feeling the urge, sitting down, pushing, and still feeling like something is blocking the way, even when they know the stool isn't hard. Some describe a sensation of incomplete emptying, where they feel like they went, but not fully. Others describe needing to shift positions, lean forward, or apply pressure near the rectum just to get anything to move. These aren't random quirks. They're classic signs pointing toward a coordination problem rather than a stool consistency problem. Understanding this distinction changes everything about how the issue should be approached, because treating a muscle coordination problem the same way you'd treat dehydration or low fiber intake almost guarantees frustration and repeated failure. So how do doctors actually figure out that this is the real cause, rather than ordinary constipation? Because the two can look almost identical from the outside, but they require completely different approaches. Getting an accurate answer matters. And if what you're hearing right now sounds a little too familiar, there's another angle you should see while this is fresh in your mind. A separate presentation breaks down why fiber, water, and probiotics may miss the real digestive bottleneck, and why an unusual underwater superfood, rich in a compound called alginic acid, is being talked about for supporting smoother regularity and a calmer gut. It also explains the surprising China connection. Adults there have been reported to have much lower constipation rates, even with diets that break the usual gut health rules. To watch it, point your phone camera at the QR code on your screen right now. There's also a link pinned in the comments. Then come right back here, because the way clinicians sort this out is surprisingly practical. The first step is usually just listening closely to the pattern of symptoms. Someone who strains for long periods, feels like stool is right there but won't pass, needs to reposition themselves, or presses on the area around the rectum or vagina to help things move. Those details all point toward a muscle coordination issue rather than a simple stool problem. It's less about how often someone goes and more about what happens in the moment of trying. From there, doctors may use a test called anorectal manometry. This involves a thin, flexible tube with a small sensor that measures pressure inside the rectum and the surrounding muscles. The patient is asked to relax and then to bear down, as if trying to have a bowel movement, and the device records what the muscles actually do in response. In someone with normal function, the pressure in the puborectalis and anal sphincter drops during that bearing down effort, showing that the muscles are relaxing. In someone with this paradoxical contraction pattern, the pressure often rises instead, capturing the exact malfunction in real time. Another tool is called a balloon expulsion test. A small balloon is inserted into the rectum and gently inflated, and the person is then asked to push it out, similar to passing a stool. In a normally functioning system, this happens fairly quickly and without much effort. When the pelvic floor muscles aren't relaxing properly, the balloon can take much longer to expel, or in some cases, may not come out at all without significant strain, mirroring exactly what happens with real stool. Imaging studies such as defecography can also be used. This involves imaging the rectum while the person attempts to have a bowel movement, allowing doctors to actually see whether the muscle straightens out the way it should, or whether it stays clamped down and continues to create that blocking angle. Seeing it visually often makes the mechanism click for patients in a way that words alone don't. What's important here is that all of these tests are designed to answer one specific question. Is the muscle relaxing when it's supposed to? Not whether the stool is hard or soft, not whether someone eats enough vegetables, but whether the timing and coordination of that pelvic floor muscle is working the way it's meant to. Once this is identified as the actual cause, the treatment path looks completely different from standard constipation advice. Instead of focusing purely on diet, the primary tool used is something called biofeedback therapy. This involves using sensors, similar to the ones used in manometry testing, to give real-time visual or auditory feedback while the patient practices relaxing the pelvic floor muscles correctly. Essentially, it retrains the brain-muscle communication that broke down over time. Patients watch a screen showing muscle activity and learn, often for the first time in years, what it actually feels like to release that muscle instead of clenching it. With repeated practice, many people are able to restore that coordinated relaxation response. Pelvic floor physical therapy often complements this process. A trained therapist can work externally and sometimes internally to help release chronic tension, improve awareness of these muscles, and teach relaxation techniques that carry over into daily bathroom habits. This might include specific breathing patterns during bowel movements, since breath and pelvic floor tension are closely linked, or techniques to avoid unconsciously bracing while pushing. Positioning also plays a meaningful supporting role. Something as simple as using a small stool to elevate the knees above the hips while sitting on the toilet can shift the angle of the pelvic floor, making it mechanically easier for the puborectalis muscle to release, even before any muscle retraining takes place. It won't fix a true coordination disorder on its own, but it removes one extra obstacle working against the body. There are also behavioral changes that make a real difference over time. One of the most important is responding to the urge to go as soon as it shows up, rather than delaying it repeatedly. Every time that natural signal gets ignored, it reinforces the disconnect between the brain and the pelvic floor. Responding promptly, even when it's inconvenient, helps preserve that communication pathway instead of eroding it further. Reducing straining itself is another key piece. This might sound difficult if straining feels like the only way to get anything to move, but the goal is to gently bear down without clenching, allowing natural peristalsis, the wave-like muscle contractions of the intestines, to do more of the work, rather than relying on brute force. This is often taught alongside biofeedback, since patients need to physically feel the difference between forceful straining and controlled, coordinated release. Managing stress plays a supporting role as well. Since the pelvic floor is so closely tied to the nervous system, practices that lower overall tension, such as diaphragmatic breathing, gentle stretching, or simply slowing down before attempting a bowel movement, can reduce the baseline tightness that makes relaxation harder to access in the moment. Now, how does someone know if this might apply to them versus just having a typical case of constipation? There are a few telltale signs worth paying attention to. Frequent straining that doesn't feel productive, even when stool isn't particularly hard, is one signal. A sensation of a blockage right at the exit, rather than higher up in the abdomen, is another. Needing to use fingers or manual pressure near the rectal or vaginal area to assist with passing stool is a strong indicator. And feeling incomplete relief even immediately after going, as though the job isn't finished, rounds out the most common pattern. None of these signs are meant to replace an actual evaluation, but they help explain why so many people quietly struggle with this for years without ever getting the right explanation. It's not laziness, it's not poor diet, and it's not a lack of trying. It's a communication breakdown between the brain and a very specific muscle that most people have never even been told exists. This also reframes a myth that deserves to be corrected directly. The idea that stuck stool always means someone isn't eating enough fiber has led countless people to pile on more and more roughage, sometimes making things worse rather than better. Excess fiber without adequate water can bulk up stool even further, and when the real problem is a muscle that won't open the door, adding more bulk behind that door doesn't help. It just increases pressure against a blockage that was never about volume in the first place. Another myth worth addressing is the assumption that this is a rare or unusual condition. In reality, studies on chronic constipation suggest that a meaningful percentage of cases labeled as simple constipation are actually rooted in this kind of pelvic floor dysfunction, particularly among people who don't respond to standard fiber and hydration approaches. It's far more common than the lack of public awareness would suggest, largely because it doesn't get discussed the way diet and hydration do. Understanding this mechanism also helps explain why some people who seem to do everything right, plenty of water, plenty of fiber, regular movement, still experience this issue regularly, while others with far less ideal habits rarely think about it at all. The missing variable was never visible in a diet chart or an exercise log. It was happening in the split-second coordination between nerve signal and muscle response, every single time the body attempted to let go. At its core, this entire mechanism is a reminder that the body relies on precise timing, not just the right ingredients. Stool consistency matters, hydration matters, movement matters, but none of it matters if the muscle responsible for opening the pathway doesn't get the message to relax at the right moment. Once that piece of the puzzle is understood, the frustrating, confusing experience of feeling stuck, despite doing everything right, finally starts to make sense, and the path toward addressing it becomes far clearer than simply reaching for another fiber supplement.